orthopedic surgery at Louisiana State University in New Orleans. I'm also the director of research for our orthopedic surgery department. So today we're going to talk about the treatment, non-operative treatment of knee osteoarthritis, and specifically examine the role of hyaluronic acid in the management of knee OA. So today we're going to explore the use of single injection HA treatments in the treatment of osteoarthritis. We'll look at different patient factors that may predict a favorable response to the treatment. And then we'll look at the differences in efficacy and the science between the different HA products available throughout the world. So we know that osteoarthritis is changing. If we look at the rates of OA in the United States, we can see a dramatic increase in the amount of osteoarthritis. But what's interesting is we're seeing a significant increase, especially in our younger patients. So in age 45 to 64, we're seeing a tremendous growth in the amount of osteoarthritis compared to even our older patients. We can only explain about 23% of that growth due to increasing obesity. We can explain about 11% of that growth due to increasing population size. But the rest of that growth, we're not exactly sure where it's coming from. The other challenge that we have is as arthritis becomes more and more prevalent, and we're starting to see it more and more, the issue that we're having is we're starting to see a significant increase in the use of total knee arthroplasty or total knee replacement. So knee replacement itself is the growth of it is pretty significant, but what's more concerning is the revisions, the redo surgeries that we're having to do, because at some point we will have problems with the original knee replacement. So one thing to think about is as arthritis grows, do we have the surgical capability and capacity to handle not only joint replacements, but revision joint replacements? When we look at the data to try to project and see what the volume of this surgery is going to be, you can see what the projections are here using the data, the insurance data from the United States. So we can see where hip and knee replacements are in 2015, and that projection is very steep in terms of how many surgeries we'll be doing in the future. Now, part of the problem with cartilage and osteoarthritis is the fact that cartilage is avascular and aneural. So the problem with this is because it's avascular, it has very poor blood flow into the articular cartilage. And so when you have poor blood flow, then the problem is you're unable to allow the cartilage to heal. The other big challenge with cartilage is it's aneural. There is no nerve endings within the cartilage. So as the cartilage becomes damaged, we don't realize this, and the patients don't necessarily have any significant symptoms until it becomes really painful. And when it becomes really painful, that's when we start to realize that a lot of the articular cartilage is gone because the pain generation is actually coming from the subchondral bone at the bottom. The good benefit of cartilage being aneural is that it doesn't hurt. So every time we walk, when we step on our knee, we would have pain. We don't necessarily want nerve endings in the cartilage either, because then we'd be unable to do a lot of the typical activities that we want to do. So when we look at cartilage, there's a few important substances within the articular cartilage. One of the big ones is glycosaminoglycans. And these are a large molecule within the articular cartilage that gives the cartilage its compressibility. It has a negative charge to it, which then absorbs the water to allow cartilage to have its compressibility. So the way you think about hyaluronic acid and glycosaminoglycans is almost like a sponge. When you open up the original packing, the sponge is very soft and the water comes in and out. But as the sponge gets older, it becomes more and more brittle, right? It's not as flexible, and then it's more easily damaged over time. When we look at osteoarthritis and we look at the biology and the cell signaling, a lot of the older thinking was that osteoarthritis was simply wear and tear of the articular cartilage. But we know it's much more complex and much more complicated. There's a lot of biology, a lot of cell signaling, a lot of cellular mechanisms that are occurring. So osteoarthritis becomes a very interesting disease because we have a lot of opportunities to target different aspects of the various pathways of osteoarthritis. So you can see here some of the cytokines and chemokines that are involved in terms of managing or causing the disease to progress. This is another depiction of some of the cell signaling pathways that we see with osteoarthritis. Again, you can see it's fairly complicated, fairly involved, and every year we're learning more and more, and these pathways are getting even more complicated. When we look at osteoarthritis, the way I describe this to my patients is if you snap open a turkey joint, if you eat non-veg, if you eat meat, and you open up the joint, you can see those smooth, white, shiny cartilage on the end of the bone. Imagine if I took a fork or some kind of damage to the end of that cartilage. Imagine if we scraped it away. That's called arthritis, and this is what it looks like over time. This is a picture from a knee arthroscopy that I did. You can see on the left side here, this is a healthy knee. We can see the smooth, white, shiny articular cartilage. This is the femur. This is the tibia. You can see the meniscus in the background. When you have arthritis and the cartilage wears away, this is what we see here. You can see all the white stuff is gone. We see this pink stuff. So this is actually the bone. This is the femur bone. All the cartilage is worn away. We can see the meniscus cartilage here is completely macerated, completely torn, very painful. And then here's the tibia articular cartilage here. So how do we measure articular cartilage wear or osteoarthritis? What's the grading tools that we use? So we typically use that you see in a lot of the research is called a Kellgren-Lawrence system, or the KL score. This was developed in 1957. So our grading system has not changed in almost 70 years. So we grade the wear of articular cartilage on one standing AP knee X-ray. And I'll show you why this is a problem, because we've learned a lot since 1957, but our tools to measure OA have not improved. But essentially, grade 0 is well-maintained joint space, so no osteophytes, almost as if, let's say an 18-year-old or 20-year-old knee, we take an X-ray, that's what it looks like. Grade 4 is essentially bone-on-bone osteoarthritis, and then we have the whole spectrum in between. So we'll talk about some of the limitations and some of the problems with the KL score and how that's impacted the guidelines and the research that's been built upon those. So some of the important things to consider is the X-rays that we choose when examining for knee osteoarthritis. One of the important X-rays that a lot of people do not get, and I recommend that you get this on every single patient that comes to see you with chronic knee OA pain, is what's called a notch view, a tunnel view, or Rosenberg view. Okay, all three almost mean the same thing. And what that is we basically have the patient flex about 45 degrees, 30 to 45 degrees, and then shoot an AP knee X-ray. Because what we're going to be doing is bringing into profile that area of the femur where we would expect the articular cartilage to be worn out. So when I get my 4 views, 4 X-rays, so any new patient that comes to me with knee pain, these are the 4 X-rays that I get on every single patient. I get a standing lateral X-ray. I get a sunrise or merchant X-ray, so I can examine what's going on with the patella. Because remember, most patients coming to see you, if you really ask them, most of the patients will point to the anterior knee where most of their pain is located. So it's very important that we image and we look at the anterior aspect of the knee, and that's the patellofemoral articulation. The third X-ray that I get is a standing AP knee X-ray, which is this X-ray right here, which is the traditional AP knee X-ray. And then the fourth X-ray I get is the standing notch or tunnel view, or the Rosenberg view, which we just described on the last slide. Now, why are these X-rays important? So weight bearing is extremely important, because if you think about it, if you're not paying attention and you just simply order an AP and lateral knee X-ray, what's going to happen is the patient is going to be placed supine on the X-ray table, and then the technologist is going to shoot an X-ray, but you're going to get artificial distraction of the knee joint. You're not going to appreciate that there's loss of joint space. So this is a patient of mine. They came with this X-ray here, and the doctor, their GP said the patient isn't responding to their treatment. They don't know why the patient has so much pain. So they sent the patient to me. The patient showed me their X-ray. I asked, were you laying down or standing up when they took the X-ray? The patient told me they were laying down. Then I had the patient stand up and look at the difference, right? With the patient standing, we had complete joint space loss, complete loss of the articular cartilage in the medial compartment with the patient standing compared to the patient laying down. Similarly, I had another patient come in. He had AP standing knee x-rays, and the GP couldn't figure out why they were having so much pain. So what I did was I took the AP Rosenberg view, the notch view or the tunnel view, and look what happened. It's bone on bone. So this is the same patient, standing AP and x-ray. You can see they have good joint space. With the tunnel view or the notch view, all of a sudden it's bone on bone. So again, it's really important, extremely important that you obtain the appropriate x-rays if we want to come up with the proper treatment protocol later. So this is a photo that I took during surgery, so I could show you exactly where the articular cartilage is wearing out in a traditional knee replacement. So this is a standing AP knee x-ray for this patient. You can see there's a lot of joint space here, but look during surgery, bone on bone. Right? So this is where the articular cartilage wear is. So on the AP knee x-ray, this is the area of the knee that we're imaging. With the AP knee x-ray, we're not seeing this part of the knee. With the tunnel view or the notch view or the Rosenberg view, this is the area of the posterior aspect of the distal femur that's coming into profile. So we're better able to appreciate the severity of osteoarthritis. So if you were to ask me, Dr. Dasa, you can only get 2 knee x-rays, only 2. Because we don't have enough money, we don't have enough x-rays. You can only order 2 knee x-rays on all your patients. The 2 knee x-rays I would order would be a standing tunnel view, standing notch view, standing Rosenberg view, right? And I would order a merchant or sunrise view. The 2 x-rays I would not necessarily order would be the standing AP and the standing lateral view, right? So those are the 2 x-rays we always get, but those are actually the last 2 x-rays I would get when trying to classify and understand the source of patients with chronic knee pain. So again, I think it's extremely important to order the appropriate imaging if we expect to have the appropriate treatment plan. So I don't know how many of you fly, but in the US, we have a lot of marketing in our airplane magazines. And so in the back of the magazine, we had someone advertising using lasers to increase cartilage within the knee. And all they did on the marketing was take the same patient, have them lay down and have them standing, and all of a sudden they said their laser is working. So now you understand how some of the marketing works with some of these practices. So the challenge is, how do we manage knee OA? And I think the traditional paradigm that most of us work in is NSAIDs and paracetamol. But we know we're having a lot of challenges with that as patients have a lot more comorbidities. They may be on blood thinners, they may have renal disease, they have hypertension. So it's becoming harder and harder to prescribe some of these medications. Then typically or traditionally, the next step would be steroids. And then ultimately, the last step would be a joint replacement or surgery. But what I want to tell you is there's a lot of treatments now, there's a lot of opportunities, a lot of innovations that we can use in between all of these steps that we should start thinking about to try to prolong the lifespan of these knees. So this is the traditional paradigm with some of those additional treatments layered in here. So these are based on some of the guidelines. So for mild knee osteoarthritis, you can see the typical treatments that we offer: exercise, physical therapy, weight loss. As arthritis progresses, we start using more aggressive treatments, simple analgesics, NSAIDs. As it gets more and more severe, then we start adding injections. In the US, there's a lot of interest in PRP, stem cells, amniotic or placental tissue now, lasers, a lot of new treatments that are coming out. Then we get into prescription medications. And then ultimately, as the severity progresses, then ultimately we talk about surgery. HA injections belong in the entire spectrum. But what we're realizing is HAs actually have the biggest impact in mild to moderate knee OA. If you give HA injections in severe OA, it may help, but I want you to realize it's not going to be that successful. HA injections really belong in this area here, mild to moderate knee OA, because we know all the new research that's been coming out over the last 10 years or so is showing HAs really have a significant impact in the early stages of arthritis. When arthritis becomes bone on bone and becomes severe, HA injections don't work as well. So you and your patients need to have the appropriate expectation if you're going to use HA injections in more severe knee OA disease. So this is a nice algorithm out of the Rheumatology Journal to help you understand all the different treatment options and pathways for managing knee OA. So this may be something where you print and you put on top of your computer, you tape it to the wall. So if you have a lot of patients with knee OA, you can quickly look at this pathway, this flow chart, and help your patients manage their treatments. So what is hyaluronic acid? Hyaluronin is a polysaccharide found in all tissues and body fluids of vertebrates. So what's interesting about HA, it's one of the few molecules that's completely preserved across all animal species. So whether you're a rooster, you're a bacteria, or you're a human, I can transfer that molecule between species and there's no immunologic response so long as the molecule is not manipulated and it is clean. There's no proteins remaining from the original animal. So if you can purify the molecule, then you can move it between species and the human does not recognize it as being abnormal. So it's very unique in that way. And that's why hyaluronic acid has been so successful throughout the world. It's a linear polymer of tremendous molecular weight, so up to 1 to 2 kilodaltons, so a very big molecule for traditional HAs, non-cross-linked. We see it in connective tissues all over the body, and you can see it synthesized in the plasma membrane, and it binds with proteoglycans to stabilize the structure of the cellular matrix. It's found intrinsically within the knee joint. It provides viscoelastic properties within the synovial fluid. So some of the mechanical properties are what actually got HA injections in the US approved. It's interesting, in the United States, HA injections are actually considered a device, not a drug. They're considered a device because when HAs first came into market, we thought that it was a device because it was providing a cushion within the knee, so it had a mechanical component, not a biological component. But we've since learned throughout the last 20, 30 years that there's a tremendous amount of biologic impact that HA injections have. But it's interesting, in the US, even today still, it's changing, but officially today, it's still considered a device by the FDA. So we know that articular cartilage begins to wear out during the progression of OA, and you can see some of the different phenotypic changes that occur during that progression. MMP, matrix metalloproteinase, those are the degradative enzymes that break down the cartilage. And there's a negative feedback loop or a positive feedback loop, depending on how you look at it, where as arthritis progresses, you see more inflammation, you have more matrix metalloproteinase, you have more cartilage degradation, which then increases the inflammation, and it becomes a vicious cycle. So how does HA work? So it can protect the articular cartilage. It can help promote increased glycosaminoglycan synthesis. So remember the molecules that provide the compressibility within the articular cartilage. We know it has anti-inflammatory effects, mechanical modifications, a lot of interest on the subchondral bone as well. And then we know it can potentially reduce pain, and we'll talk about some of that research. So in terms of chondroprotection, you can see here, HA binds to the CD44 receptor, and it reduces IL-1 beta expression, which then in turn decreases MMP. So remember, MMPs are those cartilage degradation enzymes. So if we can reduce MMPs, we can help protect and preserve the articular cartilage, okay? So we know it helps promote endogenous glycosaminoglycan synthesis, and by suppressing IL-1 beta and reducing MMPs, it creates an anti-inflammatory impact as well. We know that it can reduce the amount of synovitis within the knee, so via ultrasound. If we look at the ultrasound thickness of the synovium pre-HA injection and post, we can see that the thickness and the synovitis is reduced. We know that it can help protect the articular cartilage within the knee. A lot of interest in subchondral bone. So there's a lot of interest in bone marrow lesions, so BMLs, and potentially HA injections can impact the strength and the composition of the subchondral bone, because we know ultimately when articular cartilage begins to wear, the symptoms and the pain is actually coming from the increased forces in transmission to the subchondral bone. And then we know there's a significant impact on analgesic effects. Just in your own patients, you know, if you give HA injections, their pain is improved. So we know there's an analgesic pain reduction impact. And when we look at different animal models, we see if we harvest the dorsal root ganglion, we can see a downregulation of the pain receptors within the dorsal root ganglion. So we have a number of basic science and human projects looking at the impact of HA on articular cartilage. This is one that I think is really important, and this is one that I really like. This was a study looking at the impact of HA on the meniscus. Now, if there are orthopedic surgeons on this webinar, we all know that actually the most direct link to progression of knee OA is a meniscus tear, right? It's not direct trauma to the articular cartilage. It's not a tibial plateau fracture. It's not a distal femur fracture. Actually, if I have a patient that has a meniscectomy or a meniscus tear, you can almost guarantee at some point in their life, if they're young enough, they're going to end up with a knee replacement. So actually, the meniscus is one of the key anatomic factors that help protect the articular cartilage. And we have some basic science data showing that HA, hyaluronic acid injections, can actually help protect the meniscus. Again, we have data supporting in the basic science that hyaluronic acid can help promote and increase glycosaminoglycan synthesis. And you can see the impact of HAs on all the different inflammatory cascades within the cell. So again, we're starting to learn a lot about the biology of hyaluronic acid. So it's not so much its viscoelastic mechanical properties, the fact that it's lubricating the joint or creating a cushion, but it has a tremendous biologic response within the knee, really trying to promote more homeostasis within the knee as well. So this is a study out of LSU Shreveport in Louisiana. And what they did was they took synovial tissue from young patients undergoing ACL and also knee OA. They then stimulated the synovial tissue with IL-1 beta, so they revved it up, got it very inflamed. Then they took different HA products and they looked at the reduction in IL-1 beta and MMP, matrix metalloproteinase. And what they found was a significant reduction in human synovial tissue after inducing it with IL-1 beta, with a very powerful pro-inflammatory cytokine. They saw a significant reduction in MMP and IL-1 beta. The other interesting thing that they found was there were some products that had a higher reduction in inflammation and other products that had a lower reduction in inflammation. But what they found was the highest molecular weight, the really high molecular weight products had a better response compared to some of the products with lower molecular weights. So again, we all know that HA lubricates the knee. A lot of patients think of it almost as a gel injection. And so you can see some of the older literature around those properties as well. So again, I mentioned earlier the impact of subchondral bone. There's a lot of interest in looking at the impact and how subchondral bone creates stability within the knee as well. Here, if you look at some of the newer HA injections, if you harvest the dorsal root ganglion, like I said, we see a downregulation in pain receptors within the DRG in animal models. So there's a lot of controversy around hyaluronic acid. So we have varying guidelines from all over the world, all saying different things. So the most recent guideline that we have in the US is from the AAOS. This was published in 2013. The new guidelines are actually coming out this year, 2021. They're in the final stages of review before they will be released to the public. So there's a new set of guidelines coming out this year, but the old guidelines from 8 years ago show that there are only 4 recommended treatments for knee OA, only 4, okay? The 4 treatments are exercise, weight loss, and NSAIDs. Those are the only 3 non-recommended, non-operative treatments from the 2013 knee OA guidelines. The only surgical recommended treatment was osteotomy. Believe it or not, physical therapy actually has a neutral recommendation. I mean, steroid injections actually have a neutral recommendation. There is not enough literature to actually recommend steroid injections, but yet this is the fundamental treatment that all of us use for knee OA. So how is it that the guidelines don't even support steroid injections, right? So it tells you that the science in this space is really lacking, that we can't even recommend steroid injections, yet that's what everybody does globally. HA injections actually got a negative recommendation in these guidelines, so everyone is confused. We have the American College of Rheumatology that updated their guidelines recently, and they said the choice to use hyaluronic acid in NeoA who has an inadequate response to non-pharmacologic therapies, topical and oral NSAIDs, and intra-articular steroids may be viewed more favorably than offering no intervention. So again, it's confusing. AAOS in 2013 says one thing. American College of Rheumatology says you shouldn't necessarily use HA injections as first line, but if other treatments don't work, then it's better than nothing, essentially. If we look at the US federal government, AHRQ, this is the technology review committee that manages Medicare, which is the largest insurance in the United States. They recommend HA injections for anyone older than 65 years old. If we look, American Medical Society for Sports Medicine, they recommend HA injections with patients for NeoA. If we look at Eurovisco, they recommend HA injections for NeoA. If we look at ORSI, they conditionally recommend HA injections for NeoA. So again, a lot of controversy because the science, the original science of HA injections from 15, 20 years ago did not have the appropriate methodology because we've learned a lot. We've learned about how to do new research over the years. So the original research, when they were comparing HA injections to placebo, also included a lot of patients with severe bone-on-bone NeoA in those research studies. A lot of those studies did not include a Merchant view, Sunrise view, or a Rosenberg or tunnel view. So a lot of those older research included patients with severe NeoA, and so it was hard to demonstrate a significant difference compared to placebo. But the newer research, the newer studies, we're starting to see when we focus on patients with mild to moderate NeoA and we take the appropriate X-rays and we design the studies appropriately, we're starting to understand who the responders are and who the appropriate patients are. So if we look at the different types of HA injections that have been on the market throughout the years, we have single HA injections or multiple HA injections. When we have multiple HA injections, typically they're once a week, anywhere from now we have one for 2 weeks, 3 weeks, and up to 5 weeks, one a week for 5 weeks. They can be seen as low molecular weight or high molecular weight, and they can be avian or non-avian. We're seeing a lot of new products coming out that are non-avian. Some of the older products are avian derived. A lot of the newer products now are non-avian, specifically bacteria derived. There are a number of HA products worldwide. You can see here, the ones with the arrows are the ones that we see most commonly, especially in the United States. You can see all the different molecular weights here, the dosages, the different types of injections, and then the generic names on the right side here. So if we look at the research comparing HA injections, how do we know that single injection is equal to multi-injection? So this was a nice study out of China comparing one of the newer single injections called Durolane to ARTS, which is a multi-injection HA product. This was done in China. And they enrolled patients 40 to 80 years old. Again, look at the inclusion criteria here, only patients with KL2 or 3. So again, the newer research is starting to hone in on patients with mild to moderate NeoA, not bone on bone. And when you start to look at those patients, you start to see that it's really creating an impact. You had to have a minimum WOMAC score that you see here. What they did was they did 5 weekly injections of ARTS or SUPARTS. They did 1 injection of Durolane followed by 4 weekly sham injections. So again, this was as blinded as you potentially could be. You could see the number of patients in the Durolane and SUPARTS group. You can see they went out to 18 weeks as well as 26 weeks. And the primary efficacy variable you can see here is WOMAC. And we also in the US and especially worldwide want to know who the responders are. So it's not important just to be statistically significant, but we want the results to be clinically relevant as well. And what did they find? No difference between Durolane and SUPARTS at all the time points. So the multi-injection HA product performed identically to the single injection HA product. So you can feel comfortable when you give a single injection product that it's equal to, if not better or more convenient than doing the multi-injection HAs. So Durolane was non-inferior to SUPARTS at 18 weeks and 26 weeks. You can see the responder rate was equivalent. The use of rescue medication, which is a nice way to really assess the impact of your treatment, not necessarily what they circle on the questionnaire, but actually the use of rescue medication gives you some additional insight into the impact of that treatment, was identical between the two groups. And of course, as you'd expect, adverse events with these injections are fairly minimal. There's only one injection that creates a lot of headache for people because of the way it's cross-linked and the way it's manipulated, but it's an older single injection. We can talk about that if anyone would like to. These are the single injection HA products that are on the market. Again, you can see their constituents and the properties of them. So I helped publish this study looking at the appropriate use criteria of the treatment of HAs. Again, the science and the research in this space to really understand exactly which patient, if it's post-traumatic OA, if it's secondary OA, if it's inflammatory OA. We don't have a lot of great research out there for each different subset of OA, but in general, we tried to take the evidence as best we could and then build consensus about where we thought HA products would be appropriate. So you can see our findings here that we published a few years ago. This is a nice study looking at a head-to-head comparison of HA and steroids. I think most of us that give HA injections and steroid injections appreciate that steroid injections actually work very quickly, but they also wear off fairly quickly. So if we look at all the research that's out there and we look at the impact of steroids versus HAs, this is time. So you can see all the different weeks. If the research is has a dot down here, it favors steroid injections. When the dot is up here, it favors HA injections. So you can see early in the treatment, steroid injections work better than HAs, but after about 4 to 6 weeks, you can see HA injections outperform steroid injections. So if you want long-lasting relief, especially in patients with mild to moderate OA, HA injections, according to this research, seem to be a better option compared to steroid injections. So I wanted to, this is a study that I published as well, looking at the impact of HA injections on total knee replacement. And so what we did is we used a large administrative insurance database here in the US, and we looked at all the patients that had knee replacement, and we looked at time of initial diagnosis and then time to knee replacement. And we looked to see if the impact of HA injections delayed the time to knee replacement. And what we found was the more HA injections that you received, the longer it took to receive a knee replacement. So with a course of 5 HA injections or more, we saw a delay in knee replacement of over 3.5 years. So one of the other big questions is, you know, we've got all these different treatments that are out there. How do we figure out what the best treatment option is? We have NSAIDs, we have paracetamol, we have steroids, placebo. How do we figure out what the best treatment is? Remember, it's going to be impossible to design the perfect randomized controlled study. We can't have a 5-arm study with 5 different OA treatments, and then we're going to follow the patients for 20 years and then see which treatment is the best. It's impractical and logistically going to be very difficult, and the funding for that would be impossible. So what's the best next way we can do this? So we can take a page from big data, some of the large data analysis like Google and Facebook and all of them. We're starting to do these very high-level analytics using large databases to understand and find correlations, not necessarily cause and effect, but correlations using some big data concepts. And that is called a network meta-analysis. And so what we do is we take randomized controlled trials where we're comparing 2 different treatments. Then we're going to take that data and try to correlate what treatment effect could be between 2 products or 2 treatments that may not have had a direct comparison. So in this network and meta-analysis, they took all of these randomized controlled trials. You can see all the different comparisons from each trial, and they created this matrix. So you can see all the different studies and how each study compared the 2 treatment options. So what if we wanted to compare naproxen with ibuprofen, celecoxib with ibuprofen? So there's no study comparing the 2. So what we have to do is compare how ibuprofen performs with these other treatments and naproxen compares with these other treatments, and then we try to find a correlation. So that's what's called a network meta-analysis. So again, these are big data principles that we're starting to employ in biologic and life sciences research that a lot of the technology companies have already been doing. So what did this network analysis find? What they found was injections perform better than medications, pills, as we would expect. Of the medications, of the pills, diclofenac performed the best. What's interesting here, look at this. Intra-articular placebo actually performed better than paracetamol. So that's interesting, right? Why would intra-articular placebo perform better than paracetamol? So this is a picture from one of my knee arthroscopies. This is the suprapatellar pouch. This is the synovium in the suprapatellar pouch. And you can see it's very red. It's very inflamed. I did the knee arthroscopy, 10 minutes. And then I came back to the exact same area of the knee. I didn't touch it because the synovium, I don't do any treatment on the synovium. The surgery was for the meniscus. I came back to the exact spot of that knee, and look, all the synovitis was gone. What happened between this picture and this picture? The only difference was we were flushing the knee with saline, right? Because when you're doing knee arthroscopy, we basically flush the knee with saline. So that explains why intra-articular placebo actually had a bigger efficacy, bigger impact, effect size than paracetamol. Intra-articular placebo is essentially, right, a control, but it's an active control. So it's actually doing something. So when you have intra-articular saline, you're actually diluting the knee a little bit and actually improving the synovitis and improving the pain. So that's why you saw actually a better response to placebo than paracetamol. When we look at the different injections, you can see HA injections actually had a larger effect size than steroids. Now, if we look at the impact of placebo, so again, with the AAOS guidelines and some of the older guidelines, they did not control for the impact of that intra-articular placebo, that intra-articular saline. When you control for the fact that intra-articular placebo is an active control and actually impacts the patient's pain and symptoms, if you adjust for that, all of a sudden we see a difference in the research. So if we incorporate intra-articular placebo and the fact that it has an impact, we actually shift all the findings to the right. So we go from steroids being not clinically important to actually clinically important, intra-articular hyaluronic acid to actually becoming clinically important. So again, over time we've learned, and some of the older research didn't take this into account. So if we take into account that intra-articular placebo actually has an impact within the knee, and we look at the research to control for that and adjust for that, we see a difference in improving findings, especially with hyaluronic acid. So this is a research study that I recently published looking head-to-head, again, using one of the large insurance databases here in the United States called Blue Cross Blue Shield. And we looked at the cost and adverse events when we compare steroid injections to HA injections. We used total knee replacement as our control. And what we found was, as you'd expect, total knee replacement had higher adverse events. But when we compare steroids to HAs, steroid injections over time had higher adverse events and outcomes compared to HA injections. When we look at the use of opiates, this is very interesting. As you'd expect, the first year after knee replacement, we had high pain, high narcotic use. But after the first year, you can see the use of narcotics dropped in the total knee replacement group and actually was the same as HA. So think about this, right? Knee replacement, the pain with knee replacement that you receive, the pain relief you receive, if we measure it using opiates, is actually equivalent to hyaluronic acid. Steroid injection patients had a higher use of opiates compared to HA injections. So this is fascinating that HA injections were actually performing at the same level as knee replacement when it comes to opiate use after 2 years of the knee replacement. If we look at cost, because again, in the US right now, the cost of healthcare is very important right now, we can see a tremendous reduction in the overall cost of care in the patients that received HA injections compared to the patients that received steroid injections. And as you'd expect, a much higher cost in patients that had total knee replacement over the 4-year time span that we looked. So this is a case example of some of the patients. I think that would be good to illustrate the opportunities around HA injections. So this is a 49-year-old female, active duty military, so very active. This is her sunrise view. You can see nice maintenance of joint space of the patellofemoral cartilage. This is the notch view, the tunnel view. So again, you can see nice maintenance of joint space, lateral view. and the AP knee X-ray. So relatively good looking knee. So I'd say mild knee OA, maybe KL1, slight joint space narrowing. She has some anterior knee pain, occasional swelling. She has pain with high impact activities like jumping. Over-the-counter medications aren't working, like paracetamol, NSAIDs. She's very busy, doesn't have time to come to my office every week for 5 weeks. She wants to consider single injection HAs because she wants to protect her articular cartilage and she wants long-lasting relief. We also know with steroid injections that they can be chondrotoxic. So when we inject betamethasone plus lidocaine or any of the steroids, we can have almost 80% cell death within 15 minutes of exposure when looking at the cartilage cells after 24 hours. So again, in patients with healthy knees, we want to try to use strategies that protect the articular cartilage, that help with the pain, and don't necessarily cause more harm or cause more damage. So with that, I will pause and hand it over to Ono, and we can answer any questions that people may have.